Hello everybody, my name is Jennifer Hunter, and today I will be telling you about MRSA in the NICU and implementing an infection prevention program to help babies in the NICU. So the baby in the picture is a 25-weeker. It is a baby born at roughly 25 weeks gestation, or 4 months early. Methicillin-resistant Staphylococcus aureus, or MRSA, is a life-threatening infection for babies, especially in the NICU. So MRSA is responsible for bloodstream infections, surgical site infections, sepsis. So how can we keep these babies in the NICU from getting sick? So my PICO question is, in the NICU, does the implementation of extensive infection prevention protocols compared to standard infection prevention practices reduce the incidence of MRSA infection in babies? So the population are the NICU babies, the intervention is the extensive infection prevention, and the comparison is the standard infection prevention. The outcomes are reducing incidence of MRSA. So for my literature search, I looked at 3 databases, CINAHL, Ovid, Google Scholar. I did have inclusion and exclusion criteria, so I only included full text, peer-reviewed. I used articles within the last 5 years, and all in English so I could read them. Keywords included MRSA and NICU written out. And then I also, just to make sure I got the correct research, I also typed in quantitative, qualitative, systematic review, and then clinical practice guidelines. I ended up with 4 research articles. So the quantitative study I looked at actually looked at treating parents and not babies. So treating parents that were colonized with Staph aureus. So the medication used for these parents were mupirocin ointment in the nose and topical chlorhexidine, like washing your body with it. The study compared this to a placebo. So it included 190 neonates along with their parents that were colonized with staph. So the parents had it and not the babies at the time. So the study found that treating parents did in fact make it less likely that the baby would be colonized with the parents' same strain. Using the Johns Hopkins appraisal tool, this study, the randomized control trial, it is a level 1 and good quality. The results are not yet generalizable though. And I just wanted to tell you, in 2 slides, there's a picture of a baby and then parents touching the baby, and it just makes me think of the parents passing MRSA to the baby, just so you guys can look at that. So my qualitative study looked at healthcare workers and their perception of MRSA transmission in the NICU. So healthcare workers find that infection prevention interventions are burdensome. So the participants in the study expressed a desire to see published data supporting infection prevention. They wanted to know about contact precautions, environmental cleaning, patient decolonization. They just wanted more information. Healthcare workers also perceived families as being the main source of MRSA in the NICU, and they thought that families should play a larger role in infection prevention. For my appraisal, it got level 3 and good quality. My systematic review looked at MRSA colonization on mothers, healthcare workers, and surfaces in the NICU. So the study found that MRSA carriage was 2.1% in moms, 9.5% in healthcare workers, and 6.6% on surfaces in the NICU. They also list that numbers for different countries can be a lot higher, but the numbers they just gave you were within the US. So the critical appraisal, it received a level 2 and high quality. There were some limitations where the study talked about variations in how they tested for MRSA, so like differences between studies that they looked at. So my clinical practice guideline talked about how to prevent and control MRSA transmission in NICUs, and they do make a lot of similar recommendations to what my original studies and systematic review said. So for example, they recommend hand hygiene, contact precautions, patient isolation, patient cohorting, education and training, environmental interventions, cleaning and disinfection, dedicated equipment, healthcare personnel interventions, staffing ratios, and screening babies. But it did not recommend screening parents and screening healthcare workers. There are actions we can take to prevent MRSA in the NICU before it happens. And so medications work to stop the spread if already infected, continue with contact precautions along with screening, and be better about environmental disinfection. Also remember that healthcare workers may not want to make these changes if they don't know the evidence behind it. So educate staff on why we do this in the NICU. Thank you so much.